Neurology Quiz number 104. Describe the etiology, clinical features, and management of autoimmune autonomic ganglionopathy, or AAG. AAG is an immune-mediated disorder characterized by selective involvement of autonomic nerve fibers or ganglia. It presents with severe and diffuse autonomic failure. The onset can be acute, subacute, or chronic. The first cases of this condition were reported in the 1970s. They were labeled as acute pan-dysautonomia and were considered to be a variant of GBS. This figure shows the anatomy of the autonomic nervous system. Sympathetic outflow emerges in the thoracolumbar region from T1 to L2. Parasympathetic system is known as the craniosacral outflow and emerges from the cranial nerves and sacral spinal cord at S2 to 4. Preganglionic parasympathetic fibers in this figure are shown in solid blue, and postganglionic parasympathetic fibers are shown in interrupted blue. Preganglionic sympathetic fibers are shown in solid red, and postganglionic sympathetic fibers are shown in interrupted red. This figure shows the opposing effects of sympathetic and parasympathetic stimulation on the various body systems. Clinical features. Patients with the AAG typically present in the 5th to 7th decades of life. Onset is usually acute or subacute, but it can be slow and insidious, resembling a neurodegenerative autonomic disorder. Those who present acutely or subacutely often report an antecedent viral illness. Characteristic features of AAG include orthostatic hypotension and lower GI symptoms such as constipation in 70% of the patients. Symptoms of cholinergic failure such as dry mouth and dry eyes, as well as urinary retention and impaired pupillary responses, are also common and differentiate AAG from peripheral autonomic neuropathy or degenerative disorders. A minority of patients, 25%, report sensory symptoms in the form of paresthesias. Cognitive impairment and psychiatric symptoms have been reported in a small percentage of patients. Postulated mechanisms for these neuropsychiatric symptoms include chronic effects of hypotension versus antibody-mediated encephalopathy. Immunotherapy leads to improvement of neuropsychiatric symptoms. Seropositive patients have a unique finding on pupillometry of premature pupillary redilation with a prolonged light stimulus before the stimulation ends, whereas normally redilation begins after stimulation ends. Muscle strength and reflexes are normal. Patients with AAG may also follow a chronic and insidious course. They can present with insidious onset of orthostatic hypotension, which is clinically indistinguishable from pure autonomic failure, or with prominent cholinergic symptoms. Pathogenesis. About 50% of patients with AAG are seropositive for antibodies against the nicotinic acetylcholine receptor in the autonomic ganglia, also known as the ganglionic acetylcholine receptor antibody. The ganglionic acetylcholine receptor is composed of 2 alpha-3 subunits and 3 beta subunits and is antigenically distinct from the muscle nicotinic acetylcholine receptor at the neuromuscular junction. Patients with pupillary abnormalities tend to have higher antibody levels, and antibody levels also correlate with the severity of orthostatic hypotension. High levels of the antibody, more than 1 nanomole per liter, are quite specific for AAG. Intermediate antibody levels are seen in chronic, slowly progressive AAG and restricted autonomic failure such as isolated gastrointestinal dysmotility. Low levels of antibody, less than 0.2 nanomoles per liter, are non-specific. These may be found in 2 to 4% of healthy controls and in patients with unrelated neurological diseases, including patients with peripheral neuropathy, POTS, and systemic autoimmune disease. This figure shows the location of the nicotinic acetylcholine receptors in the autonomic ganglia, the neurotransmitter in all preganglionic fibers, and parasympathetic postganglionic fibers is acetylcholine. The neurotransmitter in postganglionic sympathetic fibers is norepinephrine, except to the sweat glands where the fibers are cholinergic. Investigations include tests for autonomic dysfunction such as heart rate variability, heart rate and blood pressure response to Valsalva maneuver, tilt table testing, and tests for pseudomotor function. Testing for ganglionic acetylcholine receptor antibodies as well as paraneoplastic antibodies, pupillometry to detect abnormalities in pupillary function. Nerve conduction studies when performed are normal. CSF examination is not required, but when performed has revealed mild elevation of protein. This is an example of one of the autonomic function tests, which is heart rate response to deep breathing. Normally, heart rate increases during inspiration and decreases during expiration, as shown here. The blue line is recording the chest movements during inspiration and expiration, and the green line shows heart rate during each phase. In a patient with autonomic neuropathy, there is no variation in the heart rate between inspiration and expiration. Another example is the head-up tilt table test with beginning and end of the head-up tilt marked by the vertical lines. There is no significant change in the systolic and diastolic blood pressure, and there is a mild compensatory increase in heart rate in response to the venous pooling of blood. In adrenergic failure, there is a significant fall in blood pressure, systolic by more than 20 millimeters and diastolic by more than 10 millimeters. There is a mild increase in the heart rate as a compensatory mechanism, but this is insufficient to counteract the drop in blood pressure. Treatment: in seropositive case of AAG, 30% of patients may show spontaneous but incomplete recovery. Immunotherapy is associated with more dramatic benefit. In small studies and case reports, IVIG and plasma exchange have been shown to be beneficial. Long-term benefit can be achieved by combining these acute treatments with oral immunosuppressants such as steroids, azathioprine, and mycophenolate. Rituximab has been reported to provide good results in some case reports. Additional measures include management of symptoms of autonomic failure, which includes treatment of orthostatic hypotension, urinary retention, constipation, and heat intolerance, as well as sicker symptoms such as dry eyes and dry mouth. Paraneoplastic, autonomic, and enteric neuropathies. Autonomic neuropathy or ganglionopathy can also occur as a paraneoplastic syndrome and can manifest as diffuse autonomic failure similar to AAG. Symptoms may be acute or insidious, and patients may have other associated paraneoplastic syndromes such as limbic encephalitis or sensory neuropathy. Ganglionic acetylcholine receptor antibodies are found in 30% of paraneoplastic autonomic neuropathies, usually in association with thymoma, with or without myasthenia gravis. Other antibodies such as anti-Hu and CRIMP5 are found in cases associated with small cell lung carcinoma. In such cases, gastroparesis and orthostatic hypotension are prominent, while parasympathetic dysfunction like pupillary involvement, sicker symptoms, and bladder involvement is less common. In some cases, especially those related to small cell lung carcinoma, there is a restricted involvement of the enteric nervous system with prominent GI dysmotility only. Seronegative AAG, 50% of patients presenting with idiopathic subacute autonomic failure do not have detectable ganglionic acetylcholine receptor antibodies or paraneoplastic antibodies and are labeled as seronegative. In such cases, symptoms of sympathetic dysfunction like orthostatic hypotension are predominant along with GI dysmotility. Cholinergic symptoms such as pupillary involvement and sicker symptoms are less common. Paresthesias and pain may be more common in these patients. In reported cases, treatment with IVIG plasma exchange and rituximab was not effective, but some patients responded very well to high-dose IV steroids.